Bismillahirrahmanirrahim. So today we are going to start with the usual notes of obstetrics. So let's get straight into them. Uh, there are like miscellaneous topics. So I will try to divide the videos into according to the topics, or maybe like in 30 minutes break or something that will be whatever will be feasible. So hematological changes in pregnancy. The very first thing that you must remember is that the plasma volume increases. The red blood cell mass increases but not equal to the plasma. The plasma volume increases more in comparison to the red blood cell mass. So that leads to decrease in hemoglobin concentration. Although you can see that red blood cell mass is increasing, but since the plasma is increasing more than the red blood cell mass, so the concentration, which is the amount dissolved in a concentration is m over v, mass in the volume. So if mass is increasing but volume is increasing more than the mass, so there will be hemodilution. So that hemodilution leads to decrease in hemoglobin concentration. Platelet count will also be decreased. Second trimester, more than 10.5 hemoglobin is normal. So up to 10.5 in second trimester instead of 12 to 16, which is normal. So if we have a non-pregnant woman, we take 12 to 16 gram per deciliter. I think it is gram per deciliter as normal hemoglobin values. But for a second trimester woman, it is 10.5. First and third trimester less than 11 is anemic woman. Now routine prenatal laboratory tests. Initial prenatal visit, RHD type antibody screen, hemoglobin and hematocrit, mean corpuscular volume, HIV, VDRL, RPR, which are the tests of syphilis, and HB surface antigen, rubella, and varicella immunity. PAP test if screening is indicated, chlamydia, PCR if screening is indicated, urine culture and urine protein. 24 to 28 weeks, we do the hemoglobin hematocrit, antibody screen if RHD negative, and 50 gram 1 hour GCT. That is glucose challenge test. 50 gram for 1 hour glucose challenge test, oral glucose challenge test. Then 36 to 38 weeks, group B streptococcal culture. Okay. Then we have chronic hypertension. To make diagnosis of chronic hypertension during pregnancy, two measurements should be elevated more than 4 hours apart. So, two measurements of elevated blood pressure more than 4 hours apart indicates chronic hypertension. Risks can be maternal, that can be superimposed preeclampsia, postpartum hemorrhage, gestational diabetes, abruption placenta and cesarean delivery. Fetal risks are fetal growth restriction, perinatal mortality, preterm delivery, increase in systemic vascular resistance and arterial stiffness, placental dysfunction, oligohydramnios. Note, poorly controlled diabetes leads to polyhydramnios. Hypertensive disorder of pregnancy. So, chronic hypertension, systolic blood pressure more than 140 millimeters of mercury and diastolic blood pressure more than 90 millimeters of mercury prior to conception or 20 weeks of gestation. Prior to conception or prior to 20 weeks of gestation, if that is present, that is chronic hypertension. Gestational hypertension is new onset elevated blood pressure at more than 20 weeks of gestation. No proteinuria or end organ damage. In preeclampsia, new onset elevated blood pressure after 20 weeks of gestation and proteinuria or signs of end organ damage. So the difference between the gestational hypertension and preeclampsia is the proteinuria and signs of end organ damage. What makes eclampsia is the new onset grand mal seizures. So eclampsia, preeclampsia and new onset grand mal seizures. Chronic hypertension will superimpose preeclampsia. Chronic hypertension in one of the following: new onset proteinuria or worsening existing proteinuria at more than 20 weeks of gestation, sudden worsening hypertension, and signs of end organ damage. What is white coat hypertension? It is seen in patients with anxiety over medical care. Causes are increased blood pressure in patients who don't have high blood pressure otherwise. It's not cause. White coat hypertension in the clinical settings, the patient with normal blood pressure have elevated blood pressure in the hospital settings. Then breast engorgement occurs 3 to 5 days after delivery when colostrum is replaced by milk, resulting in high milk production volumes. Engorgement is also exacerbated by physiological increase in interstitial edema because of decrease in progesterone levels after delivery. Symptoms: bilateral breast fullness, diffuse tenderness and erythema. Treatment is I'm sorry, just let me revise it once again. Engorgement is also exacerbated by physiologic increase in interstitial edema because of decreased progesterone levels after delivery. Okay. Treatment is done with breastfeeding, regular pumping, cool compresses, acetaminophen, and NSAIDs. Differentials are lactational mastitis. Lactational mastitis happens in unilateral breast. There is focal tenderness and erythema and fever. Breast abscess. There will be an area of fluctuancy and axillary lymphadenopathy. Memory candidiasis. It is also unilateral. Stabbing breast pain which is out of proportion to the examination and scaling of skin of nipple. Galactosile and plugged ducts that there will be a palpable mass. What are the common problems related to lactation? Engorgement, bilateral systemic fullness, tenderness and warmth. Nipple injury, there will be abrasion, bruising, cracking or blistering from poor latch. Plugged duct, focal tenderness and firmness or erythema but there will be no fever. Galactosile, subareolar mobile, well circumscribed, non-tender mass, no fever, no pain. In plugged duct, there will be pain. Mastitis, tenderness and erythema with fever. Abscess, symptoms of mastitis and fluctuant mass. What is lactational mastitis? So in lactational mastitis, as we have already seen, that this one, right? There will be tenderness, erythema and fever. Okay, and lactational mastitis over there will be unilateral breast involvement, focal tenderness and erythema with fever. Because it's an inflammatory process, as itis suggests, so there will be fever and pain as well. Inflammatory signs will be there. So there is erythema, induration and swelling, lobules, clogged inflamed milk ducts and clogged nipple pore. Galactosile, as you can see over here, like this is inflammation of the milk ducts. In galactosile, we have accumulation of milk in one of the ducts that forms a milk retention chest, and there because the one of the lactiferous duct is obstructed, and that will result in a clogged pore. Short mobile non-tender mass will be felt. Okay, then breastfeeding contraindications. The maternal contraindications include active untreated tuberculosis, HIV infection in developed countries where formula is readily available. But in underdeveloped countries, the mothers should take antiretroviral therapy with continuous breastfeeding. Then herpetic breast lesions, active visceral infection, active varicella infection, then chemotherapy or radiation therapy, active substance abuse, and the infant contraindication is galactosemia. The infant has galactosemia, we can't breastfeed the child, we have to give them galactose-free formula. It is recommended that the patient with hepatitis B and C breastfeed. However, they should abstain from breastfeeding if their nipples are cracked or bleeding, because blood can transmit the hepatitis B to the child. Cocaine is expressed into breast milk, and can lead to fetal intoxication and withdrawal symptoms. In addition, cocaine may cause long-term neurobehavioral problems, for example, hyperactivity and cognitive delay. Then, what is a molar pregnancy? So, molar pregnancy occurs when in under two pregnancies. It is basically not a pregnancy per se. It's not a viable fetus, right? So there are three situations in which molar pregnancy can occur. The classic scenario is that ovum with inactivated maternal chromosomes will receive a sperm. The sperm nucleus will duplicate itself, and duplication of the paternal chromosome will result into a 46XX chromosome. This is a complete mole. Then we have a that is 46XX. Then there is another situation in which a complete mole is formed. In this situation, there is an ovum with inactivated maternal chromosomes. Two sperms come and fertilize it, and we get either 46XX or 46XY. You must remember that 46YY is not possible. Two Ys cannot form a viable cell. There must be at least one X chromosome to make the zygote, or you may call it a pregnancy, viable. Then there is a third situation in which the ovum is normal, but two sperms fertilize it. Now it has a total of 69 chromosomes. It can either be 69 triple X, 69 XXY, or 69 XYY. As you can see, even in this situation, we need at least one X chromosome for the pregnancy, for the cell to divide. Right? This is a partial mole. None of the three pregnancies is a viable pregnancy. They are just molar structures which multiply into the uterus. Now let's talk something about a biophysical profile. It is a method of assessment of the fetal well-being during the intrapartum period. Non-stress test, reactive fetal heart rate monitoring, amniotic fluid volume, single fluid pocket more than 2 centimeter, multiplied by 1 centimeter of amniotic fluid index more than 5. Okay, so single fluid pocket 2 centimeter into 1 centimeter, more than 2 centimeter into 1 centimeter, or amniotic fluid index more than 5. 5 to 24 amniotic fluid index 2 to 8 centimeters single pocket. Fetal movement more than 3 general body movements. Fetal tone more than 1 episode of flexion, extension, or fetal limbs or spine. Fetal breathing movements more than 1 breathing per 30 seconds. So the maximum score is 10. Like these are 1, 2, 3, 4, 5 measurements. So maximum score, like every measurement, like non-stress test, that is reactive heart monitoring, amniotic fluid volume, fetal movements, tone, and breathing movements. All of these carry a score of 2. 0 is abnormal, 2 is normal for each component. Performed continuous observation for 30 minutes. A normal amniotic fluid index is 5 centimeter to 24 centimeter. Okay, using the standard assessment method, less than 5 centimeters is considered oligohydramnios and greater than 24 centimeters is considered as polyhydramnios. Here you can see components of biophysical profile can be remembered by the mnemonic Batman. That is breathing movement of fetus. A is for amniotic fluid index. T is for tone of fetus. M is movement of fetus, and N is for the non-stress test. That is reactive fetal heart rate monitoring. Good, Batman. B breathing. A is for amniotic fluid index. T is for tone of fetus. M movement, and N for the non-stress test. Then we have hydatidiform mole, the molar pregnancy. The clinical presentation is abnormal vaginal bleeding with or without hydropic tissue, uterine enlargement more than gestational age. After 20th week of gestation, there is 1 centimeter growth in the size of uterus, in 1 centimeter increase in size of fertile height every week, right? So the number of centimeter correspond to the number of weeks after 20th week of pregnancy. But if it is more than that, it is a suspicion for hydatidiform mole. Abnormally elevated beta HCG level, thecal uterine ovarian cyst, hyperemesis gravidarum, because of increased HCG, like because the nausea in the characteristic picture of a pregnancy is that woman is always nauseous, and that nausea is caused by HCG. And now if we are saying that in molar pregnancy we have too much of beta HCG, that will cause hyperemesis gravidarum, preeclampsia with severe features, hyperthyroidism because of HCG, because HCG, the alpha chain of HCG is similar to that of TSH. So there is similar, because of similar structure of HCG and TSH, there can be hyperthyroidism in these women as well. Risk factors are extremes of maternal age, either too young or too old, history of hydatidiform mole, diagnosis, snowstorm appearance on ultrasound, quantitative serum beta HCG, and histologic evaluation of the uterine contents. Management, dilation and suction curettage, serial serum beta HCG post evacuation, and contraception for 6 months. And other risk factor is vitamin A deficiency, differentials, embryonal carcinoma, elevated beta HCG and abdominal mass, but patient has ascites rather than hypertension or neurologic symptoms. Preeclampsia due to hydatidiform mole. Preeclampsia at less than 20 weeks of gestation can be a complication of hydatidiform mole. The abnormal trophoblastic tissue proliferation can result in preeclampsia and leads to an enlarged uterus, for example, pelvic mass. Preeclampsia is due to abnormal placental spiral artery development, which lead to the placental hypoperfusion, placental ischemia, and maternal hypertension. Ultrasound and echoic cystic space, for example, snowstorm appearance will be seen. Management of hydatidiform mole, suction curettage followed by serial beta HCG levels until levels are undetectable for at least 6 months to diagnose gestational trophoblastic neoplasia, if any. Okay. We keep on doing serial beta HCG measurement to check for any gestational trophoblastic neoplasia if there is one. Oral contraceptive pills are prescribed during this time period, as the pregnancy can make it difficult to determine the significance of rising beta HCG. Okay. Management of hydatidiform mole. Firstly, do the suction and curettage. Then do the weekly beta HCG level until undetectable. If it is decreasing, monthly beta HCG level up to 6 months. Beta HCG is undetectable, surveillance complete, can attempt next pregnancy. Weekly beta HCG level undetectable. If they are increasing or plateauing, diagnosis of gestational trophoblastic neoplasia. Or if initially they decreased, but on monthly surveillance, beta HCG become detectable, it is also a diagnosis of gestational trophoblastic neoplasia. Now here you can see poly and oligohydramnios. Polyhydramnios is when the amniotic fluid index is more than 24 centimeter or a single deepest pocket is more than 8 centimeter. Oligohydramnios is when the amniotic fluid index is less than 5 centimeter or a single deepest pocket is less than 2 centimeter. Chance of uterine rupture. It rarely occurs in patients who have not had uterine surgery. So chances of uterine rupture are more in the women who had previous myomectomies or maybe cesarean section, but for the women who never had a uterine surgery before, the chances are low. Category 1 tracing management expectant. Progesterone supplementation is used to prevent the recurrence of preterm labor in form of in the what form? In the form of IM. Supplementation, okay, so we give the intramuscular form of progesterone to prevent the recurrence of preterm labor. No, in form of IM hydroxyprogesterone. Okay, so we give IM hydroxyprogesterone to prevent recurrence of preterm labor. Most common cause of puerperal fever is endometritis. Most common cause of non-reactive NST is NST. What is that? Is quiet fetal sleep cycle, which lasts less than 40 minutes. Most common cause of non-reactive NST. NST is, what is NST? There was something over here. Non-stress test, that is NST. So the most common cause of non-reactive NST is the fetal sleep cycle. The fetus sleeps in the womb. So that sleep, if lasts more than 40 minutes, then that is problematic. But if you are having a non-reactive NST, repeat the test after about 30 minutes and then you will get the result, because non-reactive NST can be due to the fetal sleep. Extend the non-reactive NST to 40 to 120 minutes because of this reason. Infertility is also one of the risk factors for hydatidiform mole. Then theca lutein cysts. Presentation: multilocular, bilateral, 10 to 15 centimeter ovaries. Pathogenesis: ovarian hyperstimulation due to gestational trophoblastic disease, multi-fetal gestation, and infertility treatment. These situations can lead to ovarian hyperstimulation that can lead to formation of theca lutein cyst. Clinical course is resolved with a decreasing beta C level. Uterine atony, most common cause of primary postpartum hemorrhage. Primary postpartum hemorrhage occurs less than 24 hours after delivery. Hemostasis after delivery is achieved by clotting. Compression of placental side blood vessels by the myometrial contraction. Disruption of either of these can lead to postpartum hemorrhage. Atony occurs when the uterus becomes fatigued, prolonged labor, overdistended, that is fetal weight more than 4,000 grams, multiple gestations, unresponsive to oxytocin from saturation. Other risk factors for atony are forceps assisted delivery, hypertensive disorders, uterus is soft, boggy, and enlarged, for example, above umbilicus. Then postpartum uterine atony. Risk factors are uterine fatigue from prolonged, induced, or precipitous labor, chorioamnionitis, uterine overdistension, multiple gestation, macrosomia, and polyhydramnios, retained placenta, grand multiparity more than 5 prior deliveries. Clinical features are most common cause of postpartum hemorrhage, enlarged, soft, boggy, poorly contracted uterus. Interventions are bimanual uterine massage, correction of bladder distension, high dose oxytocin and misoprostol, tranexamic acid, carboprost, methyl gonovine, intrauterine balloon tamponade. Possible surgical intervention if atony is unresolved. And we can give methyl ergonovine in the hypertensive patients. Okay, hypertensive patients with postpartum uterine atony. Got it. Then we have, this is a picture of bimanual uterine massage. This is how we do this. Okay, the hand is in the vagina, right, and we are doing the bimanual uterine massage. Basically we are trying to stop the bleeding, because if the uterus does not contract after the delivery, the placenta was attached to uterus, like suppose there is a uterus, placenta was attached over here. Now this is no more there and there are bare vessels. These vessels can ooze blood. So to stop that from happening, the placenta must shrink, right? There must be contraction, and if that contraction is not occurring, then there is nothing to stop the blood and there can be severe postpartum hemorrhage. To avoid that, we can do the bimanual massage like this, or we can do uterine fundal massage like this. Support uterus, massage the fundus. These are cup hands, this is the fundus, this is symphysis pubis, and we do it like this. Other maneuvers can be bimanual uterine massage, we did that. Correction of bladder distension by catheterization. High dose oxytocin, misoprostol, tranexamic acid, carboprost, methyl ergonovine. Intrauterine balloon tamponade to stop the blood, and possible surgical intervention can also be done if nothing stops the blood. Postpartum hemorrhage. First line is bimanual massage and oxytocin. If that fails, tranexamic acid, which is an antifibrinolytic used within 3 hours of delivery. If that fails, use other uterotonics like methyl ergonovine. Contraindicated in hypertensive patients, causes vasoconstriction and can cause stroke. So in those patients, we use methyl. We don't give methyl ergonovine. Okay, so no methyl ergonovine in hypertensive patients. Sorry. So we can't give methyl ergonovine in hypertensive patients because it will cause vasoconstriction and that will result in stroke. Okay. Carboprost, contraindicated in asthma patients because it causes bronchoconstriction. A pelvic ultrasound may be indicated to evaluate the retained product of conception. Postpartum hemorrhage definition: more than 500 ml blood after vaginal delivery and more than 1000 ml blood after cesarean delivery. Risk factors are prolonged or induced labor, chorioamnionitis, multiple gestations, polyhydramnios, grand multiparity, and operative delivery. Causes can be uterine atony, which is the most common cause, then retained placenta, genital tract laceration, uterine rupture, coagulopathy. Treatment is done with a bimanual uterine massage and oxytocin, intravenous fluid oxygen, uterotonics, methyl ergonovine, carboprost, and misoprostol, intrauterine balloon tamponade, uterine artery embolization, and hysterectomy. Oxytocin is administered to all patients, first line uterotonic, after placental delivery for postpartum hemorrhage. I'm sorry. Postpartum hemorrhage prophylaxis. High dose oxytocin is the first line treatment for the postpartum hemorrhage along with the massage. Then there's a table. Okay, I think I should zoom it out a bit. Okay, so differential diagnosis of postpartum hemorrhage, uterine atony. The risk factors are prolonged labor, chorioamnionitis, uterine overdistension, multiples, fetal macrosomia, and polyhydramnios. On examination, there will be enlarged bogey uterus. Management is bimanual uterine massage, uterotonic medications, retained product of conception, succentriate placenta, manual extraction of placenta, and history of previous uterine surgery, enlarged bogey uterus, placenta missing cotyledons, retained placental fragments on ultrasound, manual extraction, genital tract trauma, operative vaginal delivery, laceration of cervix or vagina, and enlarging hematoma, and there will be laceration repair. Inherited coagulopathy, history of abnormal feeding in patients or family members, continued bleeding despite contracted uterus, correction of coagulopathy is the management. Then we have assessing the amount of bleeding. So this amount of bleeding, like on pads, this is scant, less than 1 in 1 is in 2.5 centimeter. This is light bleeding, less than 4. What are the numbers? 4 inches. Oh, less than 1 inch, 2.5 centimeter. If it is less than 4 inches, it is 10 centimeter. This is moderate, less than 6 inches, 15.2 centimeter. This one is heavy, that is saturated in 1 hour. Amniotic fluid embolism. Risk factor for this is advanced maternal age, gravida more than 5, live birth or stillbirth, intrauterine fetal demise, cesarean or instrumental delivery, placenta previa or abruption, preeclampsia. The clinical presentation is cardiogenic shock, hypoxemic respiratory failure, disseminated intravascular coagulopathy, coma or seizures. Treatment is respiratory and hemodynamic support with or without transfusions. Baseline fetal heartbeat is 110 to 160. Fetal tachycardia of more than 160 per minute. Maternal fever, for example, intra-amniotic infection. Medication side effects like beta agonist, fetal hyperthyroidism, and fetal tachyarrhythmias. Fetal bradycardia less than 110 per minute. Maternal hypothermia. Medication side effects, for example, beta blockers. Fetal hypothyroidism. Fetal heart block, for example, anti-Rho SSA or anti-La SSB. Neonatal lupus cause mother has Sjogren's. Actually, these antibodies are present in if these, it can happen like if the mother has Sjogren, The child can have neonatal lupus, and also at the presence of these antibodies is a risk factor for transmission of neonatal lupus from the mother. And these antibodies are also present in the lupus as well. Anti-Ro and anti-La, SSA and SSP. Okay. So these are the conditions which we have fetal tachycardia, and these are ones with a fetal bradycardia. Fetal heart beat variability. So absent or undetectable amplitude, here we have minimal, that is minimal variability, that is about 5 beats per minute. Then moderate variability is 6 to 25 beats per minute. Marked variability is more than 25 beats per minute. Undetectable or minimal variability, abnormal or intermediate pattern, etiology is seen as depressant, narcotics, alcohol or illicit drug, temporary fetal sleep, prematurity or fetal hypoxia. Moderate, that is 6 to 25 beats per minute variability, is good. It is a normal pattern. And if it is more than 25 beats per minute, it has unclear significance. It must not have both of these conditions, which were they were not supposed to happen. Coming back, we have fetal heart rate tracings. Fetal heart rate tracing category 1, category 2, and category 3. Category 1 is require all the following criteria: baseline 110 to 160 per minute, moderate variability, that is 6 to 25 per minute, no late variable decelerations, with early deceleration with or without, and with or without accelerations. This is category 1. Category 2, no category 1 or 3 intermediate pattern, and category 3 is more than one of the following characteristics: absent variability with recurrent late decelerations, absent variability with recurrent variable decelerations, and absent variability with bradycardia. Sinusoidal pattern, severe fetal anemia. Fetal acceleration and deceleration, we have wheel over chop. Okay, so VEL is variable deceleration, E is early deceleration, A is acceleration, and L is late acceleration. And what is chop? Cord compression, head compression, okay, and placental insufficiency. Okay, so basically wheel chop. If we have variable deceleration, that can be because of cord compression. Early deceleration is because of head compression. Acceleration is okay, like it's normal. And if we have late acceleration, it is placental insufficiency. So wheel chop must be remembered. Wheel chop. Okay. Early decelerations. These are caused by fetal head compression. Early deceleration by the head compression. When the fetal head descends closer to the cervix, fetal head compresses. Compression leads to narrowing of the fetal anterior fontanelle, and that leads to transition in the cerebral blood flow, stimulation of vagal response that decreases the heart rate. These are benign physiologic changes and do not require intervention. Late deceleration, that is uteroplacental insufficiency, it occurs because of placental dysfunction, which leads to intermittent hypoxemia in the fetus. Placental dysfunction can occur in the cases of late-term pregnancies more than 41 weeks of gestation due to age-related placental changes, increased placental vascular resistance. Progressive placental dysfunction can lead to chronic fetal hypoxemia with uteroplacental insufficiency. Blood is distributed more to the brain than to the peripheral tissues, which leads to decreased fetal activity and decreased fetal renal perfusion that will lead to oligohydramnios. Single deepest pocket of amniotic fluid less than 2 cm. Common cause of maternal hypotension. Maternal hypotension is common side effect of epidural anesthesia. Epidural sympathetic blockade, that is that causes vasodilation, that will cause decreased venous return to the heart, that will lead to decreased cardiac output. Hypotension, that will result in placental insufficiency, and that will lead to late decelerations. I'm sorry, I read it hypertension. Most common cause is maternal hypotension for the late decelerations and placental insufficiency. In maternal hypotension, common side effect of epidural anesthesia, when the mother takes epidural anesthesia, that will result in sympathetic blockade, and there will be vasodilation, decreased venous return to the heart, decreased cardiac output, hypotension, placental insufficiency, and ultimately late decelerations. The treatment is phenylephrine, ephedrine for vasoconstriction, vasopressors. Epidural are bupivacaine, which is local anesthetic. Fentanyl is an opioid, block the pain fibers. Then we have variable decelerations. So there is again a table. So according to this table, we have wheel chops. Variable deceleration means cord compression. Early decelerations mean head compression. Acceleration means okay, and late acceleration means placental insufficiency. Late acceleration, it was late deceleration over here, which means due to placental insufficiency. It was supposed to be late decelerations in the mnemonic, right? I think so. It is late deceleration. Yeah. The mnemonic is about late deceleration. Okay. I think we have to correct the mnemonic over here. So we were talking about variable decelerations. Well tolerated if umbilical cord compression occurs with less than 50% of contractions. Variable deceleration is because of umbilical cord compression, and they are well tolerated if the cord compression is less than 50%. In contrast, umbilical cord compression more than equal to 50%, the current variable decelerations occur, increase the risk of fetal hypoxemia and acidosis. Management of the current variable deceleration. You must remember that these changes, accelerations or decelerations, we are talking about the cardiotocography. The chart of that has accelerations and decelerations and baseline variabilities. So this is about them. So management of the recurrent deceleration is maternal repositioning, reduces the cord compression, left lateral and all fours. These are two positions. If initial management does not work, we can do amnio infusion. It increases the amniotic fluid volume and decreases the cord compression. It is contraindicated in the patient with a history of uterine surgery. Even fetal heart, if the fetal heart rate tracing becomes a category 3 tracing, which is category 3 tracing is over here, in which we have absent variability with recurrent late decelerations, absent variability with recurrent variable decelerations, absent variability with bradycardia or sinusoidal pattern with severe fetal anemia. So in these situations, if fetal heart rate tracing becomes a category 3 tracing, absent variability with recurrent variable decelerations and cesarean delivery. Sinusoidal fetal heart rate tracing, smooth wave-like oscillations with fixed amplitude of 5 to 15 minutes and frequency of 3 to 5 cycles per minute. This tracing is considered a category 3 tracing and associated with severe fetal anemia, likely from fetal blood loss from ruptured vasa previa, presents as bright red amniotic fluid. Patient with this CTG requires urgent C-section. So this is CTG's cardiotography. As you can see, this is sinusoidal fetal heart rate in the wave of a sinus waveform. These are contractions. So considered category 3 tracing and so fetal anemia. Okay. Fetal blood loss from vasa previa presents high bright red amniotic fluid and presents patient CTG will require urgent C-section. Okay. So fetal again we have the wheel chop mnemonic in which V is variable decelerations because of cord compression, E is early decelerations because of head compression, accelerations because the child is okay, and late decelerations because of placental insufficiency. Cardiotopography, we do this like it. Okay, let me zoom it in. So they are saying that we have a transducer for sensing the uterine contractions, then transducer for sensing the fetal heart rate. These are contraction, uterus, and fetal heart. Then preterm fetal heart rate tracing, increased fetal heart rate baseline and decreased variability. Low term amplitude acceleration, lower amplitude acceleration. This is because fetal heart rate accelerations require mature sympathetic nervous system, which develops at 26 to 28 weeks of gestation. Therefore, extremely premature fetuses less than 28 weeks gestation often do not demonstrate reactivity. Management of fetal heart rate category 3. Initial management of category 3 tracing is with maternal repositioning, intrauterine resuscitative interventions, oxygen administration, IV fluids, and discontinuing uterotonics. Patient removed from delivery. Patients removed from delivery that is not completely 10 cm dilated, who do not improve from initial resuscitative measures, require an immediate C-section if the fetal heart rate is category 3. Patient with complete cervical dilation can undergo operative vaginal delivery, that is with vacuum assisted vaginal delivery or forceps. This is fetal tachycardia. As you can see, their accelerations and baseline is 180 beats per minute. Variability is moderate. Accelerations are present. Decelerations are not there, and contraction is there every 3 minutes. So these are the contractions which are happening every 3 minutes. So fetal stations. So the symphysis pubis, that is this symphysis pubis level. Okay, it is the station 0 is midway between ischial spines. So 0 station is midway between ischial spines, like where this ischial spine and this ischial spine. In the line between the two ischial spine, we have a station 0, and then with the difference of 1 centimeter on each side, we have +1 or -1. So more than 1 centimeter below the ischial spine, +1, more than 2 centimeter +2, and 3 centimeter +3, and reverse is to -1 minus values. Deceleration cardiotopography description: a temporary decline in the fetal heart rate of more than 15 beats per minute for a maximum duration of 3 minutes. Acceleration in CTG is described as a normal temporal increase in fetal heart rate from baseline by more than 15 beats per minute for more than 15 seconds but less than 10 minutes. Accelerations are normal in labor, but decelerations are not normal. Uterine contraction abnormalities. There is tachysystole. Tachysystole means more than 5 contractions of uterus in 10 minutes. This means this is referred to as tachysystole. Uterine contractions temporarily interrupt intervillous blood flow. Excessive and frequent contractions lead to fetal compromise that will lead to late decelerations. Management: we do supportive management, lateral maternal repositioning, tocolysis, discontinuation of uterotonic agents. Okay, so this is tachysystole. Decelerations are happening like this, and then we have uterine contractions. Okay, tetanic contractions mean contraction lasting more than 2 minutes. In tachysystole, there were more than 5 contractions in 10 minutes, but duration of each contraction was less than 2 minutes, right? Otherwise, it would be tetanic contractions. Management: we give the tocolytics, for example, terbutaline. Terbutaline is a short-acting beta agonist. Then, how do we calculate Montevideo units? So, Montevideo units, MVUs. Calculating the Montevideo units, subtract the uterine resting pressure baseline millimeters of mercury from peak intensity, peak millimeters of mercury of each contraction in 10-minute period. Add these numbers together. Contraction strength is equal to subtract the uterine resting pressure baseline millimeters of mercury from peak intensity, peak millimeters of mercury. Adequate level is 200 to 250 multi-video units. Must have intrauterine pressure catheter in place. Okay. Then what are decelerations? Intrapartum fetal heart rate monitoring. They can be early decelerations. So early decelerations are because of cord compression. Relationship to contraction: symmetric to contraction. Like whenever there is a contraction, there is, a deceleration. Nadir of deceleration corresponds to peak of contraction. Gradually, more than 30 seconds from the onset of nadir. Etiology: fetal head compression. Wasn't it because of cord compression? Can be normal fetal tracing. I think it was because of cord compression. No, actually, early decelerations are because of head compression. I'm sorry. Early decelerations are because of head compression. Got it. So, then we have intrapartum fetal heart rate monitoring with variable decelerations. Relationship to contraction: variable decelerations are because of cord compression and cord prolapse. You must remember this. Not necessarily associated with the contractions. Abrupt, less than 30 seconds from the onset of nadir. So there's a contraction and this is onset. 30 seconds from the onset of nadir. Decrease more than 15 per minute. Duration more than 15 seconds but less than 2 minutes. Etiology is cord compression, oligohydramnios, and cord prolapse. I don't know what is nadir. Let me see that. Nadir in CT3. So nadir is basically the nadir of bradycardia was defined as the lowest fetal heart rate baseline testing at least 3 minutes during bradycardia. I think nadir is at lowest point. That is called as nadir. Okay. Intrapartum fetal heart rate monitoring and late decelerations. Now you know that late decelerations are because of wheel chops. What was S4? S was for this thing. Wheel chop. The P was for placental insufficiency. It is late deceleration. Variable deceleration because of cord compression. Early deceleration because of head compression. Late deceleration because of placental insufficiency, and acceleration is okay. So here we have the relationship of contraction in the late deceleration. Etiology is uteroplacental insufficiency. Relationship to contraction is delayed compression of delayed compared to contraction. So this deceleration is delayed in comparison to this deceleration is delayed in comparison to the contraction which is happening over here. Nadir of deceleration occurs after peak of contraction, right? Over here they were saying that it is abrupt less than 30 seconds from the onset of nadir. Contraction, the peak of contraction is here and nadir is over here. So I guess the difference between the onset of contraction and nadir is like less than 30 seconds, and gradual more than 30 seconds from the onset of nadir. Okay, etiology is uteroplacental insufficiency. Then we have twin pregnancies. We'll keep the session till here, like we're down 20 pages, and then in the next session we'll do the next 20 pages. Until next time, Allah Hafiz, fi amanillah, and take care.